Everybody to this last but by no means least session of the day. So I hope that this conversation is one that's going to keep you feeling inspired and keep you feeling connected. I know that I will in this very privileged position. So I'm Thea Stein, I'm the Chief Executive of the Nuffield Trust. But what I'm really happy to do is to introduce Jess Morley. And I thought, what's the best way of introducing Jess? And I thought, well, I'll maybe ask AI how somebody should introduce Jess Morley.
Yeah.
And AI tool told me that you're an internationally recognized academic, policy expert, and public commentator.
Oh my God, that's called sycophancy in
Yeah,
AI world.
well, yeah, we wanted to please me and you. And that you are best known for bridging academics' ethics with real-world health system policy, particularly in relation to the UK NHS and public sector AI governance. And I thought that was pretty good, actually. And then because it wants to please you and me, it went on and said, Dr. Jess Morley is influential because she understands how policy really works. She combines philosophy, public health, and regulation. She calls out performative ethics and empty AI claims, and has shaped both UK and international thinking on health data governance. So not bad. I then asked AI if I should be scared of Jess Morley.
Scared of me.
And the way in which she thinks about AI, would that be worrying to AI? And AI said that was the wrong question. And I won't go through where we went with it, but certainly AI gave me a lot, which we all know, and you've got an extraordinary career today, and I've just been finding out more about the fact that you actually have spent time in the NHS as well. And what we're going to do today is have a bit of a conversation about how AI is used in healthcare and in rapid evaluation, and some of your very interesting reflections about how individual level applications of AI in healthcare maybe aren't as valuable as we all like to think they are, and that system level can be better. And I find that really fascinating. You know, you and I have been on a panel before together where I say I've certainly been, I want to believe that predictive and personal and preventative is the future, but you have a different model. So I'm going to invite you to talk about that. We're going to reflect a bit on it. And then I want us also to reflect, and you may pick it up, on what does that mean for this audience? What does this mean for this audience of researchers? But we'll get into that. But first of all, tell me the thesis.
Might give you my pitch.
Yeah, go on.
Okay, well, first of all, thanks for having me. And I'm slightly scared by AI knowing that much about me, but it's fine. Sometimes I ask it to suggest reviewers for papers I'm the associate editor for, and it gives me my name, and that's unhelpful. Thank you. So my view on AI, first of all, is that we all should be talking about the same thing. AI has just become this kind of catch-all umbrella phrase that very often people don't actually speak about what it necessarily means. And if you boil AI right down to its sort of core ingredients, it's data plus algorithm plus model. And you're interacting with the model. But the algorithm is the thing that is doing pattern recognition or prediction or categorization in the middle, and the data is the thing that's feeding it. So you can sort of think of it as being ingredients, recipe and meal, and most of the time we only ever eat the meal, but we should also care about the other things. So that's its sort of most technical definition. The way that I prefer to think about AI is as a sort of new form of agency that separates the ability to problem solve from the ability to be intelligent, from the need to be intelligent. So in the same way that your dishwasher washes your dishes and gets them clean, but it doesn't do that in the same way as you do, and it doesn't require intelligence in order to do it. That's how AI solves problems. It solves them without needing to necessarily think about them in an intelligent way. And what that allows us to do is reconfigure the system. So if we have had parts of the system that have traditionally been joined together, so that might be, care is happening in a clinic, we can pull those things apart, but it also rejoins things together in unhelpful ways that we don't necessarily always think through the implications of. So it might join together patients and their data. So we're no longer treating the patient, we're treating the patient's data shadow. And so that's basically the way I try and think of AI.
Can you just say, because I think I don't understand what you mean by patient and patient's data shadow. Just tell me what you mean by that, just so I know.
So where we have gone from seeing the whole patient,
right.
And instead now when we're using about AI, particularly when we're talking about things like predictive modelling and personalised modelling, it's not actually ever interacting with the whole patient. It's interacting with what's recorded about that patient in their data.
Yeah, got it.
And that might be their electronic health record, it might be their wearables, it might be things like your step count, but it isn't a reflection of the whole patient.
Okay, yeah.
And so that's why this term data shadow, which actually I think is a Health Foundation term, so from a few years ago. And so that's how I like to think about AI, is this sort of system-level capability to help us reconfigure the system. Now, where I think things are going slightly wrong is that we are using all of that power essentially to do things that we have already done slightly faster, so to try and improve efficiency. Hence, we try and do all of this stuff with regards to ambient scribes or modelling of waiting lists or all of that type of thing. And increasingly this idea that I'm going to take every single piece of data about a person, what they eat, what they, all of that type of stuff, and use it to basically come up with a personalised risk score.
Yeah.
That's the narrative that comes through very strongly in like Fit for the Future and various other strategies that exist in the UK and in the US. I have quite a significant issue with that because when we look at the performance of those models, they're really bad. Really, really, really bad. So we did a systematic review a little while ago and of all of the risk stratification tools that are deployed in the NHS. So risk strat being predicting who is most likely to go into hospital and therefore can we intervene earlier. And what we show in that systematic review is that a third made some benefit, like a tiny benefit. A third of them made absolutely no difference, and a third of them made care worse.
I mean, I've heard you talk about this before, and we've been on a panel about this before, and I do think that knowledge is striking, and that systematic review is probably not as embedded in, well, it's not embedded in NHS thinking at all, because we still want to believe in it, and it is about belief, but carry on.
Exactly, and the reasons why those things fall over are quite simple. Some of them are because, as you know, you've heard earlier in the day today, that they're very rarely evaluated. So about a fifth of those tools, 1/5, had been validated externally. None of them had been validated internationally, and yet most of them were coming from the US and then being deployed in the NHS. And so you have this complete context collapse. But the main one is that they misunderstand causality. We're trying to predict based on individual factors, based on the factors that are things that are recorded. Very rarely is that the thing that we can actually act on. Very rarely is the thing that is conducing risk is the thing that allows us to actually act on and reduce risk. It's association rather than causation. It can work in some scenarios. For example, precision medicine in oncology works very well. There are some sort of specific cases. But if your intention as the healthcare system, especially in this country, is to raise the population's health, not individuals' health, this idea that you're going to predict on the causes of cases rather than the causes of incidents and therefore raise everybody up to a certain level just doesn't work. Instead, we have, population health theory from the 1980s showing that all that does is tweak like a tiny amount of people. And so my view is flip that narrative on its head, and instead, when we talk about prevention, do primary prevention, talk about moving things upstream. Use AI as a way of understanding how to intervene in the system in a way that we haven't been able to do before.
Right.
So use it to understand what is really driving the causes of incidents. Why is town A versus town B sicker instead of why is Jess versus Dia sicker? And we haven't been able to do that before. It's been largely intractable. We've had people talk about it. You've had Michael Marmot talk about the social determinants of health for decades, but actually being able to act on it has been intractable. AI gives us the ability to do that we didn't have before, and I think we will get more benefit from using it to do things that we have been unable to do previously, rather than trying to use it to do things slightly faster that we actually already do and don't necessarily make any difference.
Have you got examples where people have used it in the way in which you describe? Have people taken that more system focus and utilised it to make change and benefit?
Yeah, there are a few examples that they're popping up all over the place. So there's one example where they're looking at access with regards to young people. So this is typically people between the ages of around 15 and 25, and why there are inequities in care with regards to access. And using it to actually take a systems level approach, so to model the way in which those people are being able to move around town, what is actually driving their cases of illness. And so they've had some really good examples of that. There's a bunch of people actually here in the UK who work with the government who are using satellite data to understand better where there are, for example, pockets of health inequalities and what that looks like and how do you model things. And the big one I think we've spoken about before is diabetes. I think most people in this room and others will know that diabetes is largely a system level issue. And even if we can predict who is most likely to get type 2 diabetes, we can't really do an awful lot about that if you can only access or reach a couple of people, and if it's the environment that's driving up their risk. And so there is some really interesting work with a few people who are doing sort of systems level modelling to understand how do you lower the incidence of diabetes. But this is all early.
So there's no results of a town that's lowered the incidence of diabetes or anything?
No, not yet. There is lots and lots of really interesting theory going on. There is less actual actionability happening yet.
Do you think people should stop using the individual prediction risk stratification tools that are currently being actively rolled out across the whole of the NHS? Just saying. If you were in control, would you be, and who knows by tomorrow whether or not you may be health minister, if you were, would you say stop? Would you say don't use them at all? While people from ICBs cry at this point.
Would I say stop? Yes. At least yes, in the sense that I think using them as this, it's all under the umbrella heading of population health management, right?
Yes,
so this idea that I can take a risk, an individual level risk prediction tool, and run it at a group level.
Yes.
And that's going to tell me how to manage my population.
Yes.
That is a misunderstanding of epidemiology. It's quite often a misunderstanding of actual screening criteria and of the way in which you would do risk stratification in public health. And as I said, it's quite often a misunderstanding of causality, because how you manage a population is not how you manage an individual. So those things conflate. That being said, it doesn't mean that it can't give you a useful insight into, for example, what the overarching health of that particular population is, but it doesn't, I think the way that we then use it in terms of then saying, okay, well, we should ring up Mrs. Jones and tell her that this is going to happen and therefore she should do this. But it can help with, I think, commissioning decisions. And we have seen, GPs have traditionally been very good at doing this when they look at their overarching patch and they look at who they're looking after, and they think, oh, well, this person, I haven't seen this person for a while, maybe I should call them up. That thinking can still work. Where I think it becomes really, as I say, risky, is outsourcing this idea that to entire population health management, I think is concerning, and the empirical data backs that it's concerning.
I mean, it's a really serious, different position that you're positing here. You know, it's very counter to the prevailing push within the current English health service system that genuinely sees population health management and the predictive use of these tools as being very much beyond the good GP that phones up the patient they haven't seen, but saying this will be the way we save our hospitals, will be the way in which we ensure that people with one long-term condition don't get two, with two don't get three, etc. We will not have the pressure on services, etc., etc., etc. And you're saying the evidence doesn't really support that that's going to happen?
No. Not in a way that then is in keeping with the NHS's overarching ethos of delivering excellent care at the point of need for everyone. I think what that's going to do, if you go back and you look at Jeffrey Rose's population health theory, is basically what this is a high-risk strategy on steroids. That's essentially what we're doing. We're taking a very small number of people who we can predict accurately for and trying to optimize their individual health.
So we could actually make inequities worse.
Significantly worse. So when I talked about that third, the third we made healthcare worse for the people who were not targeted by the model. So they're basically the people who are misinterpreted or misunderstood by the model. There's an enormous amount of problem with what's called in AI terms target misspecification, which is essentially choosing the wrong outcome and really focusing on it. And it normally happens because the middle thing that you're predicting of is a proxy for the reality, and so you get a problem with the sort of continuity or the validity of that intervening variable. A really, really famous study was done by Obermeyer et al. With regards to healthcare utility in the US, but it would also apply here, where they were looking and they were like, okay, and what they found was that when they were doing this risk prediction, the amount of health intervention that was being predicted as needed for white patients versus people of colour was massively different, even if they had the same level of sickness. They were basically saying, oh, the white patients, they need loads and loads of intervention, and they're going to be, they're very high risk, but the people of colour are super low risk and we don't need to intervene.
And was that because of the information that being fed into the system?
It was because they used the wrong proxy. They used a proxy which was healthcare utilisation.
Right.
And they were basically predicting on historical healthcare utilisation to predict future risk. And of course, as we all know, that people of colour have had traditionally less access to care, they have had less spent on their care, and so when you use that as the predictor of risk, they were being predicted as lower risk. There are all sorts of incidences. It's happened in sepsis, it's happened not with people of colour, that was a different thing. It's happened also in a very famous incident with people who had pre-existing lung conditions and pneumonia, and it's all because of this target misspecification problem, and all it does is massively amplify inequity.
It's really good examples, because I think probably everybody in this room will know that, in a sense, rubbish in, rubbish out, and we all know that in terms of data and the way we understand it, and we all know that AI has got a lot of very racist data that goes into it, etc., etc. But nevertheless, I think I speak for myself, as you know, I feel that sort of, we still want the magic to happen.
Of course.
We still want the magic to happen, and I think you're bursting my bubble here. It's just really sad. The magic isn't going to happen using these predictive tools in this way, potentially. And that's so important to know at this point.
I think what it is as well, and we can say this in this room, and we can, because it's important to have uncomfortable conversations,
yes.
Right? There is this idea of basically in sort of in tech determinism, and it's called the politics of avoidance, right? The problem is we've had decades now of austerity. We've underfunded population health. We haven't kept up with looking at the ways in which people drive sickness. And the healthcare service is being asked to pick up the slack. And
Yes.
this is why everybody is under pressure. It's very, very appealing to come in and say, hey, this is my shiny piece of tech that's going to solve everything, because I can put that in a press release or in the King's Speech, and I don't then have to go in and say I need to do all of these actually much harder things that are to do with reinvesting in social housing, or looking at my food policy, or looking at why did we take physical education out of schools. Those are harder conversations to have.
Absolutely.
And so AI has become a little bit of this sort of mechanism for avoiding having awkward conversations. And this is the thing where I really struggle with the population health management idea with risk prediction, because it's shifting responsibility from the system to the individual. It's,
Yes.
it's philosophically, this is what we're saying, is if I've told you your entire risk and you do not act on that risk, regardless of the fact that the model doesn't actually understand whether you have the capability or the resources to act on that advice I've given you, if you then do not follow up on my risk prediction and you become sick, it's your fault.
Yeah.
Even though most of the time that your fault has actually happened all the way up here.
I suppose if I was channeling, being health minister at the moment, I would say, but we are situating that tool within our concept of neighbourhoods, and we're saying the neighbourhood should be thinking about those other things like the obesogenic environment, like access to green space, like a whole range of other things. So we're not just using the tool on its own, we are going to situate it within this wider partnership of people, and that's going to enable us to do it, and so it will save the world, Jess.
It will. It's definitely going to save the world. AI is going to solve death. Everything's okay. I mean, yes. And I think if that was what was genuinely happening, if we were thinking of it as being an insight tool, as it being a research tool, as it being something that can help me think, okay, where do I join all of these disparate pieces together? And this is why I talk about systems thinking and systems levers and modelling at that level rather than modelling purely at the individual level. Then I think, yes, of course it can be extremely powerful. Like I said, this idea is that precision oncology probably has an enormous amount of benefit to be getting at. We probably do have some benefit to get from understanding which groups are at higher levels of risk, but we should be using that as a signal, not as the deciding factor. What worries me is that I think very often AI, and I hear this from people all over the NHS right now, feel as though it's foisted upon them to solve a specific task without it being thought through as a care pathway thing, and it not necessarily joining up all of the dots of now how do I actually act around that. And that's also one of the reasons why you get this massive performance drop once the models actually go into the real world.
Slight change of tack just before I open up the floor for questions. So do be thinking about questions and putting things onto Menti as well. I'll come to the floor and also to Menti. But, quite a lot of people are very worried that AI is coming for their jobs. And people in this room who do research, both qualitative, quantitative, rapid evaluation, maybe also thinking, well, this is all very interesting and academic as well, but how does this world of AI and how does this world of predictive tools or this world of modelling, does it come from my job? Do I use it as a tool in my job? What does it mean for this audience? I mean, I'm just interested as an expert, your reflections on that.
Okay, so there are a few different levels to that. First of all, is it going to come from my job? No. This is nonsense. We have a paper that's coming out in the next 2 weeks that's called Not Even Wrong, and we go through every single prediction about job losses that has been made over the last 15 years and show that every single one of them was off by a mile, mostly because they involve doing this. And so no, it might change the nature of your job, and there is a need to be adaptive. And then there are different ways in which you can do that. So I think I get a reputation sometimes as being an AI skeptic. I'm not. I'm a skeptic of AI solutionism and exceptionalism, not of AI itself for specific tasks. I think it can be extremely useful as a research tool. I use it myself. It's extremely good at highlighting things that you should already know. And reminding you. It is useful for stuff that we find terribly boring and don't want to deal with it, invoice management, that type of thing, where it becomes, so everybody should feel, that they're able to use it for those purposes. Where it means for people in the room, if you're clinically, it means use it, but use it wisely as a critical friend who is going to help challenge your assumptions and help you, remind you if you've something forgot. Never, ever, ever turn off your own thinking and try and keep a critical view in your mind. What it means for policymakers and analysts is it can give you capability to do analysis that was previously either too expensive or too large scale or too complex that you can now do, and that can release new insights. But again, the sort of solid thing that you have to do in that regard is still stay very firmly in control. People have got very worried about provenance and this idea of, if somebody used AI, that makes it less real, or that's cheating, or something like that, whether that be in research, or whether that be in consultancy, whether that be in policy making. I don't think it matters if people are using AI for those purposes. In fact, I think it's probably good. It can level us up. What does matter is responsibility and accountability for the information being correct.
Yes.
And so that has to stay with you.
Okay, excellent. Let me go to the room and see what questions there are in the room. Otherwise, if you can scan, as you've probably done during the day, that, and then we can see the questions that we can use there. But are there questions in the room as well that anybody wants to put their hand up for? Otherwise, I'll go to the Menti questions. Can't see, don't want to talk in the room? We're going to talk through computers. Probably aligns with where we are, which is fine. Okay, let me have a look at all the questions that are here. But as we start with the one that I've got on the screen, how can we QA AI outputs because it hallucinates?
Well, so first of all, hallucination is a problem that is specific to generative AI, not all types of AI. There are several different things you can do. There are some things that are more technical, and there are some things that are less technical. Technically, you can never eradicate the problem of hallucination because that is what those models are designed to do. They are predicting, and therefore they sometimes, if they don't know what is the right prediction, as in I don't know what the right sentence is in this, or I don't know what the most logical next step in this person's care pathway would be, so let me make it up when I put it in the record. That is what they are designed to do, so you cannot eradicate that problem. How you can mitigate it is, first of all, just by keeping your own brain turned on. If something looks too good to be true, it probably is. This happens a lot with citations, and you've just seen this massive study that Nature has done and published in terms of the number of hallucinated citations. If you get given something that says, this study backs up my exact theory on this thing, it's probably not real, and you can go and check it. So keep your critical thinking and your sort of sniff test turned on. More technically, there are things you can do if you are using generative AI, whether that be Claude, whether that be Gemini, whether that be ChatGPT, any of them, called harnessing, which is essentially the infrastructure that sits around the model. That makes it more personalized to you, and then you can do that by, for example, changing the temperature setting on these different models so that they hallucinate less. You basically give them less space to play with. So you say, I want you to play in this tiny space. You can do things like build skills. Claude, this is something that Claude lets you do. And by doing that harnessing, you lower the risk of it hallucinating. But the absolutely main thing is you have to stay in control.
Keep your brain on.
Yeah.
Yes. And it's a bit like, you know, we've all used Google Maps for years, and it will take you down a tiny side road, and you think, this doesn't look right. And as you learn, you think, no, because it isn't right.
Yes,
you are going to get stuck. And it's sort of the same thing, you know, keep your brain active. Just because you're using this new tool, it's not going to be everything. So good question. How can we act? Oh, no, I was going to ask them. You mentioned that AI wouldn't be effective for population diagnosis, but could this change in the future? Should healthcare data become more standardised with broader metrics? You know, so could this get better?
Yeah, it could get better, but there are several things to that. There is a data question, and then there's a logic question. So data question, yes, we can use better data in terms of understanding the actual causes of health, which is really what I'm talking about. In that case, you know, we need better data on how people move through cities. We need better data on climate. We need better data on all of these different things, and we need better data on linking it together. The UK has got very, very good, wide, but fairly shallow data sets. You know, we have a lot of small amounts about a lot of people. We really need to be able to layer that up to create deeper data sets. Where I feel slightly cautious about saying that is that sometimes that gets interpreted as meaning we just need to build bigger predictive models. We need to build
I was going to say that could sound like that, couldn't it?
Beefiest prediction model that there possibly is, and that's wrong, because that forms the same logical flaw. That just because I can predict it doesn't mean I can change it. So our ability to do the type of system level modeling that I was talking about will change if we get better data. That will also change as we get new techniques and we try different uses of optimization. That's not the same as saying we will be able to get better at predicting personalized risk and that suddenly becoming the solution to improving population health.
Okay. So a question that people have liked as well is, how can we act so the evidence that you've presented, and no doubt others do, about the use of AI and the evidence about risk stratification tools can be utilised rather than the serious lobbying you get from health tech companies who are keen all the time for these be implemented in the NHS at scale? What sort of movement could people like this be part of to make it clear?
So I think there are two things. There's a higher level thing, and then there's a lower level, more practical thing. At a higher level thing, it's that lobbying is seen as a massive problem. People really tend to focus on lobbying as being a problem that only arises at the regulatory level. They talk about regulatory capture and this idea that tech companies are trying to push for lower levels of regulation so that they can innovate more freely. That's definitely happening, but I think in health specifically, it's actually a much wider problem that I refer to as epistemic capture. I think the tech companies have captured the entire pipeline. So they are the ones who are saying these are the types of questions that we should ask, and therefore these are the types of solutions that we should build. And that has happened for a variety of reasons, which we could talk about historically for hours, but that is the nature of what has happened. So people in rooms like this need to feel that they are able to be in the room where the decisions are being made much earlier in the chain. So we need far more signalling from the ground as to these are the problems that we're actually facing, and this is what we genuinely want you to use AI to solve, and feel to participate in policy conversations. I don't know if you had a question.
No, I was just thinking, because, you know, you and I were talking before about the book by your colleague whose name I completely forget now. Carissa, about power and prediction, and how this is something we've seen through history, actually, where Roman emperors like to have oracle and fortune tellers next to them. President Trump likes to have Elon Musk and Jeff Bezos beside him.
Unfortunately, yes.
And actually, that is all about that desire that prediction gives you power. And I find it a really interesting hypothesis and really interesting writing from your colleague. And I think it's very challenging for people in this room, for all of us, to feel you describe epistemic capture, to get into the room at the right point. Because there is such a huge belief in the English NHS about these predictive tools, etc. It's hard.
It's completely hard, which is why I was going to say that the other end of the scale, in terms of more practical steps, is ask really awkward questions. So there is a real tendency for people to just believe that the emperor is wearing the most wonderful clothes when the technology companies walk into the...
Yes.
And because the NHS does not yet have a standardized way of evaluating whether or not these tools are the right things for them, although we're trying to build one, that is something that's really missing. So the only thing that you can do in that particular moment is ask the world's most basic questions that will feel really daft to you, because you'll think, well, this is completely obvious, but I can almost guarantee
Tell us those questions we should be asking.
Who does it work for? When was it tested? How long can this run before the performance drops off? What data set was it trained on? Have you tested it in an English NHS system? Do I have the actual variables that this model predicts off? That's a really, really crucial one. Very often you'll get people who come in and they say this model has an AUC or an accuracy level of 90%, and then you put it in the hospital and the hospital doesn't collect the variable that it predicts off. It's like, okay, that's useless. So try and ask those kind of interrogative questions. And always remember that there are two axes. There is the complexity of the tool, and then there is the readiness of your organization. Yes. And generally, those two things are trading off. The higher the level of the complexity of the tool, the more ready your organization needs to be, both technologically and from a governance perspective. Very, very simple tools, something that's literally just summarizing your notes, for example, that you are checking is one thing. Using something that, Dragon Copilot is one thing. Using something like this thing called Hippocratic AI, which is an agentic system, yes, is a totally different thing.
Yes, I've seen Hippocratic AI.
Yes.
I think this is something I've heard people say, it's sort of broader one again. There's an argument that cognitive and analytical skills will degenerate as AI is easier than all these people in this room using their brains and summarizing, critically appraising information. And that this means there'll be even more of a rise of misinformation, and also that people will stop thinking because they're using these tools. I mean, I think that is a real...
I think that's a genuine risk.
Yes.
It's called technically automation bias, so this tendency to think that the computer is always right, and therefore to always defer to it. There are two things that I think are important to that. One is just you maintain your critical thinking skills. I think sometimes in policy there's a bit of a tendency to say that everybody has to become a data scientist. They need to be able to understand the model in order to be able to critique the model. That's not true. You just need to be able to think critically about the outputs.
Yeah, well, you just gave us some great questions, which are questions that you have just because you're using your brain and your thinking. Yes.
So you've got to keep sort of that level on. And then the other thing is, just remember where this stuff has come from, especially generative AI. Generative AI is trained on the internet. I don't know how many people in here have been on the internet and see what's written on there, but just keep that in the back of your mind when you're interacting with it.
Brilliant. Can I ask one more question? Oh, okay. And then I'm going to, right, where's the questions in the audience? Yes, here.
Hi, just on that question of automation bias, which is a real thing, and I've seen it both theoretically, well, you can't see something theoretically, but I know about theoretically, and I've seen it in practice. What do you do in a system that in many ways is very risk-averse and where there's a large blame culture, right? Where if a machine of any kind, or in fact any form of research, tells you to do X, right? If you go along with X and it's the right decision, if you have a good outcome, well, nobody notices, right? And if you go against X and it's a bad outcome, you get nailed.
Yeah.
Or if there's, I think we have to understand the sort of psychology and the culture behind risk awareness and decision-making and all of that, how do you, in practical terms, work against automation bias when the natural thing is to default to the machine? Because actually, as a human being, you're putting yourself much less at risk if you do what the machine says.
So I think there are things that have to happen at a regulatory level, which is why I think that we have to we need there to be far greater clarity with regards to liability and negligence. That really needs to be far, far clearer, because at the moment it sits with the clinician, and that is going to push people in the direction that you're talking about.
So,
yeah.
Having done some work actually in a regulatory organization around
yeah.
disciplinary procedures for people, I'm not sure that that regulatory clarity is actually going to solve that problem.
Yeah, so I don't think it will solve it completely. I still think it needs to exist. In terms of then at a more local level, I think this is what I'm talking about, organizational readiness. That, like, loads of organizations just simply do not have a policy in place that says this is what to do in this scenario, and this is how we keep the people who are interacting with these tools safe. This is what we should do. So I think that needs to happen more systematically, is that there are policies put in place at a local level that are designed with the people who are using those tools in mind, that says, well, in these scenarios, this is what is okay and is not okay, and at least makes people feel safe. I do not by any means think that this is a simple problem to solve, but that I think there needs to be more protection at different levels of the governance chain. But, yeah.
Okay. I'm going to take a question right at the back of the room. There's a gentleman with his hand up. Somebody with their hand up?
So,
I only saw a hand.
it's on. There we go. So on the question of automation bias,
Yeah.
you've given us some questions that we can ask as individual users of AI, but as professionals who might be interacting with people who are using this in less questioning ways, and as people who are part of a society where these skills might be dropping, what can we be doing to try and influence things to get better in our professions and at a systemic level, at a societal level? What are the little things that we can be doing to help other people retain those skills?
Do you mean other people who are, for example, members of the public who are using AI to help with clinical tasks and like ask its questions of it, or do you just mean other people who might be at risk of feeling outsourced or displaced by AI?
Other people who are using AI in ways that need that critical input and they're maybe not using it critically.
Okay.
Big question.
It's a huge question. I think it's multi-layered, and it comes back a little bit to the second part of the question, answer to the question previously. Some of this is about design. So there are other ways in which we can think about how we design these systems so that they are better at protecting the user's autonomy at the other end. So generative AI, for example, is trained and designed. I was joking at the beginning about being sycophantic, and it is trained also to sound warm and empathetic and like it agrees with you, which is the sycophancy thing, and it's also trained to be incredibly persuasive in the way in which it presents information to you. This is like a fact. Those are all design decisions, so therefore they are things that can be influenced at the design level in which these things are done. I think greater level of pressure should be being put on the developing companies to say, hey, the way in which you are designing these things is inherently manipulative and we don't like it. In terms of other things that can be done with wider forms of society, I think we all have a greater responsibility in terms of encouraging a buyer beware attitude. I mean, this is something that this is a thing that has existed for a long time in the world of apps and digital therapeutics. This is largely the same thing. I think we should be encouraging people to think about, okay, yeah, this is what this is doing, but maybe I should be aware of the fact that it's limited. And that, again, has some implications for regulation and design, but it also has sort of implications for how we interact with people. And I think the main one on that last point is to not be patronizing and to not shy away from the fact that this is happening. I think sometimes there is a bit of a tendency to sort of deny, people are being silly, like why would you ask Claude that particular question, and think that it's people being naive. The reality is that that's what is happening, so we have a responsibility to try and teach people how is the best way to interact with these tools rather than pretend that it's not happening, which is exactly what I did with my students who I teach in Yale. They are all using AI like for everything. Me pretending that they're not is unhelpful. Me telling them how to interact with it and use it properly and maintain their critical thinking skills is far more useful for me as a teacher than it is for anything else. So any ways in which you can do that as a productive member of society, I think, is something that is helpful. Yeah.
I think that's absolutely right. And I guess I'm going to finish by asking you to go back to this audience, and we've got rapid evaluators here, and somebody's asked, what are the research questions and that rapid evaluation could help address?
What is the
Any
outcome?
ideas? Sorry.
What is the outcome?
Yeah.
Is basically the main question, and this comes back to this point of target specification. So the entire thing is, what is it that we are trying to achieve, and how do we measure whether or not it has actually achieved that? We need to move beyond just thinking about statistical accuracy and validation and data drift and performance drift. What are the system level goals that we want to achieve with the use of AI, and then work backwards? And that is going to teach us how to do a rapid evaluation in a way that's meaningful, as opposed to a way that is not really designed for the tool that we're evaluating.
Thank you. I'm going to go back to my AI companion,
Okay.
who told me that you're frequently described as a clear-eyed critic of digital transformation and that you're genuinely impressive. And although I believe that it was trained to be a sycophant,
Yes.
I think you genuinely are, and I think we should say thank you to our speakers. So, before you leave, I'd like to just invite up Johnny Clark, who's going to say a few words to finish today.
Brilliant. Thank you very much, Thea. Thank you very much, Jess, for a fascinating and thought-provoking way to close today's conference. I'm conscious that I'm standing between you and your journeys home and any last conversations you want to have with friends and colleagues before you go. So I'll be brief. I'm Johnny Clark. I'm a Senior Policy Fellow at the Health Foundation. And I just wanted to reflect that today's been a really rich day. We've heard about rapid evaluation in a system that's changing quickly, driven by a continuing pressure to act fast, but also to act wisely. And that tension was really at the heart of today's conference. Rapid evaluation is needed precisely because decisions are moving quickly. But as we all know, it only works because it's credible, useful, and connected to the realities of the care that we and patients and the public experience. Just reflecting on a couple of themes that have come out for me from what we've covered today. The first is that evaluation is not just about whether something worked. It's about who it worked for and what context it happened. At what cost? What sort of unintended consequences emerged? Did we bother to look for them? And with what implications for equity, for staff, for patients and communities? And then secondly, rapid evaluation, to be useful, it has to be close to decision making, but not too close. We need to be responsive to the pressures that policymakers are facing and commissioners and local leaders are facing. But we also need to preserve our independence as evaluators to be able to honestly provide unbiased evaluation that is useful to them rather than just meeting what we think they want to hear. Sometimes that means helping a good idea spread, Sometimes it means helping people adapt. But sometimes, as we discussed in the decommissioning session this morning, it means helping the systems let go of things that are no longer adding value that they used to add, if they added value at all. And we've covered so much ground over the course of today. We've talked about AI just now, learning health systems, economic evaluation, maternity services, neighbourhood health, and how we involve the public in our work, and plenty more besides. Those are really different topics, but they point to the same challenge. Health and care systems are making important decisions in the context of uncertainty, and rapid evaluation is one of the ways we can make that uncertainty more transparent, more manageable, and also less risky for those making decisions. And before we close, there's 3 things I've got to do, sort of housekeeping related things. First thing is you should very shortly receive an email that contains a link to a feedback form. If you could complete it, that would be extremely helpful. It's helped us in previous years to try and make the conference better each year and to continue to align with what you want from a conference like this. Secondly, recordings of the sessions that have been recorded will be available next week, sometime mid-next week, I think, Becky, is that right? Brilliant. And then thirdly, I've got to do loads of thanks. So I want to thank our speakers, our chairs, panelists, contributors, everyone who's joined the discussions and the breakout sessions, our patient public contributors, the teams at the Nuffield Trust, the Health Foundation, BMA House, and also to our advisory group who made today's conference happen. The conference is now in its 8th year, and it's gone from strength to strength and really shows the generosity of us in the rapid evaluation community. But most importantly, I wanted to thank you all for being here, for your enthusiasm this year and last year and all years before it, and your willingness to ask challenging questions of the panelists, but also of each other. You really do make the conference what it is. I hope that you leave today with at least one new idea to try, a new connection to follow up, and maybe, particularly based on the session that we've had just now, an assumption to question. Safe travels home. I hope you stay dry, and thank you all very much.